Ajimsha.
Ya.
Dokter Ayu memberikan topik untuk hearing screening diagnosis cochlear implant ya, mengenai kandidasi dan persiapannya. Sebenarnya ini refreshing aja ya, kita refreshing slide. Kita lihat bahwa seorang bayi pasti membutuhkan perkembangan bicara ya dan bahasa dari mulai lahir, dan pentingnya bahwa semua ini akan terjadi kalau kita mempunyai pendengaran yang baik ya. Dan tentu kalau seorang bayi di dalam perkembangannya mengalami gangguan pendengaran, ini akan mempengaruhi perkembangannya. Dan yang penting adalah hearing screening ya. Jadi buat bukan adik-adik ya, anak-anak ya. Kalian tuh anak-anak saya gitu ya. Jadi buat anak-anak saya di sini, bahwa yang dibutuhkan adalah sekarang kita menggiatkan hearing screening ya, supaya kita tahu hearing screening itu sebenarnya apa gitu loh. Ya, kalau kita di RSCM-nya udah rutin melakukan seperti itu. Slide. Ya, kita lihat bahwa ini dilakukan untuk mengidentifikasi seorang bayi lahir itu apakah dia mengalami gangguan pendengaran ya. Lanjut, agak cepat aja ya. Nah, bagaimana kita lihat bahwa bayi itu lahir, kita sulit untuk melihat, misalnya kita kalau lagi di daerah gitu ya, mungkin sulit kalau kita cuma lihat dari behavior anaknya aja. Tapi yang kita butuhkan adalah bahwa kita harus mendeteksi secara benar ya. Kadang-kadang kita bilang oke, kita nggak punya alat, kita nggak punya OAE, kita nggak punya apa-apa. Mana ya? Ini bisa masuk dari sini nggak? Oke. Ya udah nggak apa-apa. Kita lihat bahwa ini tentu akan mempengaruhi semua perkembangan sampai ke pendidikannya. Lanjut, cepat aja. Ya. Prinsip daripada hearing screening tentu harus cepat, ya, murah, tidak invasif, akurat, dan kalau kita mengulanginya itu akan terjadi hal yang sama, ya, hasil yang sama. Lanjut. Nah, target sebenarnya ada universal, ada yang targeted ya. Kalau kita di RSCM ini masih yang targeted ya. Kita lihat di SCN 5 atau di NICU atau apa. Kita belum bisa universal karena di RSCM sendiri kita masih mendapat rujukan. Tetapi kalau di rumah sakit yang di luar swasta mestinya ini sudah universal ya. Lanjut. Nah, kita harus tahu faktor resiko ya. Faktor resiko ini harus kita pahami dulu. Kapan kita mau melakukan screening ya, jadi kita harus tahu apa sih yang harus dilakukan. Misalnya dalam 28 hari dan dalam sampai 2 tahun ini kita harus lihat. Ini paling banyak nih ya, bilirubin, infeksi ya. Juga kalau kita lihat kraniofacial anomali, ini juga salah satu indikasi untuk screening. Lanjut. Nah, di luar paling banyak mereka cuma melakukan OAE aja. Padahal kita tahu auto acoustic emission hanya melihat fungsi daripada sel rambut luar. Ya, sedangkan AABR ini kita lihat untuk potensial aksi daripada saraf cochlearitis, ya, saraf pendengaran. Jadi yang paling utama adalah harus kombinasi ini. Karena apa? Kalau kita melakukan cuma OAE aja, tahu-tahu anaknya pas 2 tahun kok nggak ngomong, ya. Karena kita tidak melakukan pemeriksaan AABR. Ya, jadi harusnya yang namanya screening ini kombinasi OAE dan AABR. Ya, ini kita lakukan kalau di RSCM kita lakukan. Ya, lanjut. Nah, kita lihat bahwa hearing screening bisa dilakukan 2 hari, dalam 2 hari ya. Misalnya sebelum anak pulang. Nah, 3 bulan kemudian kita boleh melakukan diagnostik ulang ya, pengulangan pemeriksaan, apalagi kalau dia ada risk factor. Nah, sebelum 6 bulan kita lihat kita harus mengintervensi. Ini nih yang lama sebenarnya ya, 2009. Sekarang tuh dipercepat malah. Ini bukan 3 bulan lagi, tapi ini jadi 1 bulan, 2 bulan, kemudian di bawah 3 bulan. Ya, yang terbaru. Makin cepat kita intervensi, maka makin cepat hasil yang diperoleh itu makin baik. Lanjut. Nah, kenapa kita mesti cepat-cepat? Karena kita lihat kalau grafik ini kita lama ya, kita lihat perkembangan daripada baik visual, taktil ya, sensori ataupun pendengaran akan mempengaruhi baik sensori, language ya, kemudian kognitifnya. Kalian lihat deh, dia puncaknya di mana? Coba 3 tahun untuk kognitif, plastisisi otak. Nah, kalau kita baru mulai habilitasinya di sini, Kita udah turun nih sebenarnya grafiknya. Ya, jadi kenapa buruh harus diintervensi di daerah sini? Itu yang paling penting. Ya, tetapi bukan berarti bahwa kalau kita mendapatkan kasus di sini terus kita bilang, oh udah nggak bisa apa-apa lagi, nggak juga. Ya, kita tetap harus berusaha. Ya, walaupun memang usaha itu akan lebih berat dibandingkan kalau kita melakukan habilitasi di daerah sini. Ya, lanjut. Next. Ya, ini HTA yang kita buat ya di THT.com ya waktu itu. Ya, ini kita tambahkan waktu itu dengan neuropatik auditori ya. Jadi dulu 2006 kemudian diganti 2010 ya oleh kita dari THT.com ini memperlengkapi ya. Nanti kalian bisa lihat sendiri. Lanjut. Saya akan lebih cepat. Nah, habilitasi apa yang kita pilih? Tentu kita mulai memilih dengan hearing aid ya. Hearing aid kita lihat, kemudian kita evaluasi. Kalau tidak berhasil dengan hearing aid, tentu kita pindah di cochlear implant. Apalagi kalau dia misalnya profound ya. Nah, kita lihat perbedaannya adalah bahwa hearing aid itu cuma punya eksternal komponen, sedangkan CI ada eksternal internal, kita nggak pakai operasi, ini hanya amplifikasi, ini langsung stimulus ke nerve. Harganya beda ya, dan hasilnya juga beda ya. Tetapi kita tetap harus mulai dengan hearing aid. Lanjut. Nah, kita lihat di sini ini komponen-komponennya, nanti mungkin akan diterangin juga oleh Mr. Ajimsha ya. Ini kita lihat bahwa transmitter ini yang kita lihat kalau orang pakai cochlear di sini ada mikrofonnya, ada speech processornya, lalu kita lihat ada magnetnya yang akan hubungan dengan yang dimasukkan dalam implan koklear. Lanjut. Nah, indikasi. Kalau mungkin yang dulu kita pakai indikasinya adalah tuli berat, sangat berat, bilateral. Ya, ingat ya. Dulu tuh tuli berat, sangat berat, bilateral dan tidak mendapat benefit daripada hearing aid. Tapi sekarang udah ganti semua. Ya, ini udah ganti karena banyak teknologi yang berubah. Ya, next. Nah, ini kenapa? Karena kita memperhatikan juga dengan residual hearingnya. Dulu kan saya bilang tadi berat, sangat berat. Sekarang 70 dB kita udah lakukan. Ya. Kemudian bagaimana dengan pengenalan kata ya. Kemudian operasinya menjadi lebih mudah. Dokter Harim terakhir mengerjakan pada usia 6 bulan. Ya, bilateral, cochlear implant ya. Nah, kemudian dulu anatomi. Dulu kita maunya anatominya tuh 2,5 lingkaran. Sekarang mau common cavity juga udah kita lakukan banyak. Tapi memang hasilnya nunggu waktu lebih lama. Tapi hasilnya baik juga. Ya, tapi tidak sebaik yang mempunyai anatomi yang lengkap. Ya, jadi kalau misalnya kita menemukan antara 12 sampai 22 tahun ya dengan profound ini udah lebih dari 90 udah kita lakukan. Tapi kalau di sampai 17 tahun dengan 70 aja kita udah langsung implant ya. Lanjut. Nah, ini beberapa kandidat ya, contoh dari seleksinya ya tadi sama, hampir sama. Ya tidak ada benefit dengan hearing aid. Jadi kita mempercepat memperbaiki pada keadaan yang lebih awal ya dengan lihat word recognition-nya. Kemudian kita lihat dari usia 4 tahun, kita lihat berapa sentence yang dia punya ya dengan hearing aid. Jadi itu sangat penting kita lihat apa dia bagaimana menggunakan hearing aid, seberapa besar dia ada benefitnya. Lihat, lanjut. Nah, kita unilateral juga kita lakukan ya. Kemudian yang severe frekuensi hearing loss juga kita lakukan. Jadi walaupun dia masih datar di low frekuensi, mid frekuensi, tetapi begitu turun high frekuensi kita juga bisa melakukan dengan cochlear implant. Nah, pertanyaannya adalah kan yang masih low sama mid masih baik, ya. Kita mengejar hearing loss di high frekuensi. High frekuensi kan kita lihat letaknya di basal cochlea. Jadi biasanya yang diaktifkan adalah yang bagian basal aja, tetapi elektroda tetap dimasukkan. Saya bertanya sama dokter Harim, nah terus gimana dong kalau sisanya? Iya kita memperkirakan, soalnya nanti kalau sampai dia turun juga di low dan mid frekuensi, kita tinggal aktifin alatnya. Ya, jadi high frekuensi aja kita lakukan CI. Genetik pasti audit auditory neuropati, ini pun kita harus lihat ya. Kemudian postlingual, banyak sekarang kita melakukan banyak orang-orang tua ya dengan postlingual. Nanti saya ada kasih contoh dengan video ya. Jadi ini dia nggak punya benefit juga dengan hearing aid. Kemudian kita lihat juga dengan speech-nya bagaimana, kurang dari 50% pada yang akan diimplantasi atau 60% bilateral ya. Lanjut. Nah, yang absolut ya jelas kalau kita nggak punya cochlea, nggak punya nerve ya, atau lesi di brainstem atau cranial nerve, atau juga misalnya dia mempunyai mental retardasi atau apa ya. Kalau ini tidak akan dilakukan selama dia masih akut ya, masih ada infeksi. Diperbaiki dulu ya. Kenapa ini mental retardasi dan kalau misalnya dia ada masalah? Karena kita mengingat proses belajarnya. Kalau kita udah pasang, terus orangnya nggak mampu belajar, ya cek juga ke bagian yang bersangkutan, apakah masih bisa ya epilepsi, kemudian misalnya yang tidak memungkinkan, misalnya dia orangnya punya duit, tapi dia adanya di pedalaman Irian contoh. Terus kapan siapa yang mengurusin? Siapa yang mau mapping dia? Kecuali orangnya mau pindah misalnya ke Makassar yang paling dekat atau Surabaya, nunggu 1 tahun. Ya, karena pengalaman saya pertama kali implan itu banyak orang yang dari daerah nginep atau kos-kosan 1 tahun di Jakarta, memperbaiki dulu, udah bagus baru mereka pulang. Ya, nah ini apakah orang itu mau ya tinggal atau kos-kosan di tempat yang ada fasilitas? Walaupun punya duit, tapi kalau nggak ada fasilitas, siapa yang ngurusin? Siapa yang mau ngajarin dia ngomong? Siapa yang mau mapping dia? Siapa yang mau melakukan evaluasi? Nah, ini penting ya, kita juga harus pikirkan hal-hal seperti ini. Lanjut, lanjut slide. Nah, persiapannya tentu kita harus anamnesis benar, pemeriksaan ENT seperti biasa, audiologi, radiologi, kemudian yang pemeriksaan lain sesuai dengan handicap yang ada. Misalnya dia ada masalah dengan mata, kita konsul ke mata, ada masalah dengan jantungnya, kita konsul ke jantung dan segala macam. Dan yang penting adalah persiapan harus melakukan imunisasi. Karena kita melakukan pemboran pada kornea, tentu kita nggak mau infeksi berlanjut sampai ke otak ya. Kemudian yang penting juga adalah ekspektasi daripada orang tua. Kita harus tanya, dia maunya anaknya diimplan untuk apa? Ya, ini kita harus jelaskan. Kalau memang kondisi anaknya tidak memungkinkan atau tidak sesuai dengan ekspektasi daripada orang tua, ini kita harus jelaskan. Kemudian hearing aid history ya, jadi riwayat dia menggunakan hearing aid kita harus tanya. Ya, lanjut. Ya, tentu motorik, jangan lupa ya motoriknya ya. Nah, waktu di hamil ini kita kejarnya di infeksi terutama TORS. Ya, kamu mau nanya apa? Tentu kamu tanya pernah nggak ibu demam, ada ruam-ruam di kulit atau apa ya? Atau ada riwayat keguguran? Kita mikir ada tokso apa enggak? Seperti itu. Ya, kemudian ketika lahir apakah dia asfiksia jadi Apgar skornya jelek, dia ada bilirubin, kemudian mungkin juga kalau kita lihat apakah kepalanya tuh kecil ya, kemudian anaknya kuning sekali, kita mikir, kalau anaknya keadaan seperti itu kita mikir apakah itu CMV, ya, kongenital, ya. Ini sering diagnosa kalau yang sudah masuk di THT.com sering didapat rujukan ini adalah atresia biliar atau dibilang kolestasis, tapi sebenarnya itu biasanya CMV. Ya motoriknya, kalau kita nggak mau juga ada global delay ya. Lanjut. Ya, ini pemeriksaan saya rasa ini yang rutin kita lakukan ya. Ini harus kita lakukan sampai kita mendapatkan ASSR untuk persiapan kalau dia mesti habilitasi dengan ABD dulu. Lanjut. Nah, ini pemeriksaan MRI CT scan perlu kita melihat anatomi daripada koklea dan juga saraf pendengarannya. Lanjut. Nah, ini hearing aid-nya kita harus lihat bagaimana riwayatnya, berapa lama, apakah dia pakai reguler. Kadang-kadang orang, saya pakai alat bantu dengar, tapi apakah dia continue? Enggak, cuman ya paling 10 menit sehari, ya enggak juga seperti itu ya. Kita mikirkan gini, kalau dia pakai alat bantu dengar aja dia lepas-lepas, terus kamu mau kasih cochlear implant dia udah beli mahal-mahal, terus dia nggak continue pakai, percuma juga hasilnya. Ya, kemudian bagaimana progresnya dengan alat bantu dengar dia udah bisa apa? Lanjut. Nah, kita lihat bahwa sebelum implan tentu orang akan menggunakan visual, ya. Jadi dia lebih banyak menggunakan visual. Jadi kita harapkan setelah implan maka kita membutuhkan auditorinya. Dia harus dengar, ya. Jadi jangan lagi berebutan dengan visualnya. Ini yang penting. Lanjut. Nah, kenapa saya bilang ini yang melatih adalah otaknya, ya. Mau cochlear implant, mau ABD itu hanya sarana untuk informasi masuk ke otak. Tapi yang belajar tuh otaknya, ya. Bagaimana dia mendengar lalu dia menginterpretasi, ya. Jadi otak yang dilatih, ya. Ini PR banget, ya. Lanjut. Dan ini harus kita jelaskan kepada orang tua, ya. Nah, ini kita lihat dalam habilitasi, ya. Habilitasi itu apa? Melingkupi apa? Audio verbal terapi. Dia harus di mapping, mapping. Kemudian kita jangan lupa evaluasi. Ini evaluasi penting. Kadang-kadang ini kelupaan nih. Pokoknya dia udah AVT, mapping, terus kita nggak lihat evaluasi. Padahal diperlukan evaluasi supaya kalau ada kekurangan kita bisa memperbaiki mappingnya atau AVT-nya. Itu harus diperbaiki setelah kita melakukan evaluasi. Biasanya yang bagus adalah evaluasi 1 bulan, 3 bulan, 6 bulan ya, sampai 1 tahun. Dan kita berlanjut secara berkala. Lanjut. Nah, kalau kita mengaktifkan alat, pertama dia pasti mendengar, ada suara. Kemudian akan berpindah menjadi lokalisasi. Dia tahu arah suara, kemudian dia bisa membedakan, kemudian dia bisa berbentuk kalimat, mengerti sampai di pemahaman. Ini udah tinggi. Jadi pemahaman, ya. Lanjut. Nah, ini evaluasi ya. Kita sekarang pakai CAP 2 ya. Jadi dari mulai skor dari 0 sampai 9 ya. Bagaimana sampai 9 kalau dia bisa pakai telepon ya, dari orang-orang yang tidak dia kenal. Ini berarti dia udah excellent banget ya. Tapi kalau 0 dia belum awareness, itu biasanya yang pertama, kemudian di awareness itu baru CAP 1 ya. Biasanya ini 6 bulan sudah mulai terlihat ya. Lanjut. Nah, bagaimana dengan speech-nya? Kita mulai dengan six link ini. Harus dikuasai dulu ya sama anak, ya. Jadi jangan mengedukasi orang terus kemudian dia bilang, mama, papa, mata, ini. Nggak ada kayak begitu. Dia harus bisa bilang A dulu, O dulu, E dulu, M dulu, SH. Ini dikuasai dulu baru bisa nyambung. Ya, jadi ini yang pertama. Ya, ini ada karena ini huruf-huruf ini ada di frekuensi bicara. Ya, ini yang paling penting. Dia harus nguasain dulu. Ya, kadang-kadang dia nggak bisa bilang S atau SH. Kadang yang paling gampang adalah A. Ya, lanjut. Nah, ini kalau kita lihat bagaimana untuk speech-nya. Ya, dia dari 1 sampai 5. Kalau 5 berarti orang itu bisa berbicara dan dimengerti oleh orang lain. Ya, jadi evaluasi. Kadang dia bicara terus kemudian kita nggak ngerti. Ya, ini skornya masih di mana? Mungkin masih low. Ya, kita nggak ngerti. Ya, jadi ini semua dievaluasi. Ya, lanjut. Nah, kesuksesan, keberhasilan. Ya, usia operasi, penyebab ya, hearing levelnya gimana, uni atau bilateral, hearing aid bagaimana, ada riwayat progresnya enggak, handicap yang lain. Dan yang paling penting buat saya adalah sini, komitmen untuk habilitasi. Dan kerjasama orang tua, terapis, audiologis, dokter yang menangani ini paling penting. Ya, jadi kalau 2 orang operasi pada saat yang sama, umur yang sama, ambang dengar sama, belum tentu hasilnya sama. Ini paling penting di sini ya. Kenapa saya merahin seperti ini? Ya, lanjut. Nah, ini orang tua juga harus lihat nih, ya. Kadang-kadang tidak diperhatikan ya, sehingga rusak. Ya, orang tua kadang-kadang nggak tahu kalau baterainya tuh udah karatan, ya. Harusnya disimpan dalam box yang baik, ya, pengering, ya. Dan ini orang tua harus tahu bahwa pemakaian implan minimal tuh 10 jam per hari. Kadang kalau kita lihat di yang sekarang alat-alat yang baru, kita bisa lihat data lognya. Kalau kita bilang orang tuanya pakainya berapa lama? Pokoknya selama dia bangun dok. Tapi kalau kita lihat di data log, ternyata dia cuma pakai 1 jam, 2 jam. nggak efektif banget ya, minimal 10 jam ya. Kemudian kita lihat bahwa setiap pagi orang tua harus monitor respons anak ya dengan 6 link itu. Kemudian lihat penempelan elektroda magnet kadang-kadang jadi bengkak atau merah ya, karena iritasi. Itu juga orang tua harus memperhatikan seperti itu ya. Kemudian monitor hearing dan speech-nya. Kemudian kita harus edukasi kepada orang tua bahwa ini nggak instan ya, perlu waktu. Dan saya melihat itu perlu waktu sekitar 3 tahun baru orang bisa TikTok dengan baik ya. Lanjut. Ya ini saya kasih contoh, bisa nggak ya? Ini dia coba jalan sambil jalan aja. Bisa jalan nggak videonya? Ini anak ini operasi cukup muda ya, 2 tahun kalau nggak salah. Eh, orang tuanya benar-benar yang support banget sehingga dia tuh bisa berbicara dengan baik. Suaranya nggak ada ya? Nah ini dia bikin konten ya. Anak ini sampai sekarang pun masih kontrol. Sampai udah seusia gini, tiap tahun dia kontrol. Ya, jadi ini makanya saya bisa evaluasi dia. Suaranya kemana dek? Nah kemudian tadi salah satu juga yang tadi saya bilang adalah postlingual. Kadang-kadang kita berpikir kalau dia masih aktif di dalam hubungan sosialnya, maka dia juga memerlukan pendengaran yang baik ya untuk berkomunikasi dengan orang lain. Bisa nggak? Nggak ada suaranya ya? Ada yang salah?
Halo teman-teman, aku
Nah,
Kopi Kirani.
jadi ini dia bikin konten ya. Ngomongnya kalau kita lihat anaknya bagus banget ya. Uang ya. Jadi dia ngomong, kita nggak tahu kalau anak ini sebenarnya lahir dengan anak yang tuli ya. Next, yang pasien berikut. Nah ini ada satu orang ibu postlingual ya. Yang lanjut postlingual. Kebetulan dia 2 hari yang lalu saya baru mapping lagi. Dia ini profound. Kemudian
Ibu
ini orang
Kiki
dari
apa
Bandung ya.
kabar?
Tapi saya melihat bahwa support itu yang datang
Ibu
tuh dari
Kiki apa
suaminya kuat
kabar?
gitu ya. Dia 10
Iya,
tahun dia
ulangi
hearing
ya.
loss, ya nggak bisa dengar. Sudah 3 kali ganti alat bantu dengar, ya dia udah beli berganti-ganti 3 kali, nggak berhasil juga. Akhirnya diputuskan untuk implan. Dan sekarang dia 4 bulan pasca implan dan dia happy banget karena sekarang dia tuh bisa mengikuti pengajian, tidak saja harus yang tadinya mesti lihat mulutnya Ustadz, tapi dia berpindah di dekat apa namanya? Speaker, apa sih namanya? Speaker, dan dia bisa mengerti dan dia happy banget loh. Jadi saya coba, oke, kamu jangan lihat saya juga akan nunduk dan saya akan menguji kamu bisa nangkep nggak suara saya. Dan ternyata bagus banget, bahkan suaminya dan dia happy banget ya bahwa dalam 4 bulan tuh dia udah bisa dengar dengan baik. Silakan kalau bisa ke ini ya.
Kucing, kucing, ayam, ayam, kuku, kuku, gigi, gigi, hitam,
Jadi saya minta
gajah,
tidak baca.
gajah, ular, ular, apa, 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 ama, 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 aka, asa, hitam, makan, nasi, sapi,
Ya, udah boleh di stop.
ada.
Ya, boleh di stop. Jadi inilah yang saya katakan bahwa kita kadangkala cuman memikirkan, oke, kita cuman habis operasi selesai, tapi evaluasi jangan lupa. Karena di dalam evaluasi kita lihat kalau ada kekurangan, kita perbaiki dan kita cari solusinya. Mungkin ini dari saya. Terima kasih banyak.
Terima kasih banyak Dokter Mira, thank you very much. Sekarang kita beralih ke sesi tanya jawab. Silakan apabila ada pertanyaan dari floor audience. Ada yang mau bertanya? Ya, silakan. Sudah ada dok yang punya tangan.
Terima kasih dokter atas kesempatannya. Izin bertanya dok, untuk dalam proses habilitasi sebenarnya waktu terbaik untuk kita evaluasi kapan dok? Dan kapan kita nyatakan sebagai kegagalan sehingga kita bisa melakukan intervensi lanjutan dok? Terima kasih.
Oke, sekarang evaluasi. Evaluasi yang saya lakukan adalah pertama, kan kita mengaktifkan alat ya, mengaktifkan alat, kemudian 2 minggu kemudian kita akan mapping kembali. Nah, sekarang mungkin kalau kalian baca, orang mengaktifkan alat 2 minggu pasca operasi. Sekarang saya sama dokter Harin 2 hari aja saya udah aktifin alatnya, ya, aktifin alatnya, orang boleh pulang ke daerahnya. Kemudian 2 minggu dia tinggal tempel dan dia sudah bisa pakai program. Saya akan buatkan berapa program. Nah, evaluasi saya akan lihat dalam 1 bulan, 3 bulan, 6 bulan, 1 tahun. Nah, di dalam perkembangan itu kalau misalnya ada yang kurang-kurang, itu kita bisa perbaiki. Apakah mappingnya, apakah memang karena dia tidak melakukan AVT dengan baik, itu harus kita evaluasi. Jadi kalau dia sampai sudah bisa mengucapkan kata-kata, kita evaluasi lagi huruf apa yang hilang. Misalnya M dan N suka terbalik-balik. Kemarin ada anak yang T dan M terbalik-balik. Nah, itu kita harus perbaiki di dalam mappingannya. Ya, jadi evaluasi itu harus berkala dan setahun sekali. Kenapa setahun sekali juga? Kita evaluasi apakah elektroda di dalam itu masih berfungsi dengan baik. Karena ada saya menemukan bahwa orang itu tidak datang kembali mapping dan orang tua mengatakan, anak saya kok nggak ada respons ya. Padahal setelah saya lihat, karena tidak diperiksa misalnya impedansnya gimana, ya ternyata alatnya udah mati gitu loh. Nah, kadang-kadang orang itu tidak datang kembali atau dia datang ke tempat lain, orang yang melakukan mappingan atau evaluasi itu, dia tidak melakukan pemeriksaan. Jadi elektrodenya udah mati, dia nggak tahu gitu loh. Nah, itu kita harus lihat satu persatu. Kadang-kadang saya mengulang, periksa kembali elektrodenya berfungsi baik, kemudian apakah responsnya masih ada atau tidak. Kalau misalnya elektroda ada yang high impedance, jadi dia ada yang rusak, itu mesti kita matiin gitu loh. Jadi tetap 1 tahun sekali paling tidak. Setelah dia stabil, setahun sekali kita melakukan evaluasi.
Terima kasih.
Silakan.
Dokter Mira, lagi mungkin pertanyaan? Silakan.
Udah jelas?
Menarik sekali dan jelas sekali ya.
Ada
Silakan.
siapa?
Terima kasih dok atas kesempatannya. Izin bertanya dok, kalau misalnya pada pasien dengan SNHL berat atau profound yang kemudian memilih untuk pemasangan ABD dulu dok, kemudian kira-kira berapa lama kita harus evaluasi atau pemantauan untuk misalnya bila dengan ABD saja dia tidak perkembangan komunikasinya tidak berjalan dengan lancar, kapan harus kita pertimbangkan untuk pemasangan CI dok?
Oke,
Terima kasih, dok.
kalau saya lihat dari kepustakaan kita mulai misalnya kalau kita pasang ABD umur 6 bulan, kita boleh evaluasi sampai 6 bulan, sampai umur setahun itu masih diperbolehkan. Tapi kalau di atas itu kita cukup 3 bulan juga udah kita evaluasi. Kalau nggak bagus, tapi dengan catatan ya pemakaiannya continue, kemudian dia melakukan terapi. Kalau gagal mendingan kita langsung. Karena tadi kurva itu, kita kejar kurva itu. Ya.
Baik dok, terima kasih.
Terima kasih. Ada lagi pertanyaan dari floor? Baik dok. Jadi intervensi dini itu sangat diperlukan ya,
Ya.
dok.
Justru buat kalian intervensi dini penting. Ya. Secepat kita melakukan deteksi dan intervensi itu yang paling penting. Ya.
Baik. Terima kasih banyak Dokter Mira atas kuliahnya yang sangat jelas dan menarik. Kemudian next we will have our second lecturer, Dr. Ajimsha, audiologist MBA, the head of Advanced Bionic in Southeast Asia. Dr. Ajimsha is an accomplished audiology professional with over 18 years of experience in cochlear implant technology. So, Dr.
Thank you.
Ajimsha, time is yours.
Thank you, Dr. Ivy, for the introduction. Thanks, Dr. Mira. It was a great lecture to know about the candidacy, and thank you for the opportunity to come in and talk. It's always a pleasure to come and talk to all of you. I don't speak Bahasa, so I have to do this in English. Terima kasih and satu dua I know. So, and teta warpanas. That's all I know in Bahasa. So nothing else, but I'll try in English. So yeah. So you just heard from Dr. Mira regarding the candidacy, who needs a cochlear implant and how cochlear implant would help a patient, how it benefits. We will talk, me and my colleague Janani later, we will talk about I don't know why this is here now. So we'll talk about the cochlear implant from the technological perspective and also from the habilitation and therapeutic perspective, how we can enlighten those people and enrich those people with hard of hearing to come up to an active member in the society. Before we get into more deeper about advanced bionics, I just want to speak a bit about the company as such. Has anybody heard the name Advanced Bionics? No? Very good. So I can, it's not. Does it work? Okay. It's slow. So I'm sure you might have not heard Advanced Bionics. So we belong to a bigger group of company called the Sonova, which is the world's largest. No. It's okay. Oh. Okay, now I know if I press it takes 2-3 minutes to change. See, this is technology, right? And I'm talking about technology, and it's a good start to do it. Let's see if this works. Okay. So we belong to a bigger group called Sonova, which is the world's largest hearing healthcare group. I didn't do that also. So don't look into that. There are certain brands that you must be familiar. Has anybody heard the name Sennheiser? Sennheiser headphones? Yeah, you go to any airports, you usually see Sennheiser, Bose, those kind of headphones. So belong to us. And also we have a hearing instrument division where we make all the hearing aids like Phonak, Unitron, Hanseton. These are all world-famous hearing aids. Again, belong to us. We have the cochlear implant division where we make the cochlear implant, and an audiology retail where we, even diagnose, test, and prescribe hearing aids and implants for people around the world. The advances of having this is, imagine you going to a headphone shop and you put Sony headphones and you put a high quality, let's say a Bose headphones, the same music, same everything, but you can immediately see a difference in hearing. How does it happen is because of the technology it uses. Same applies even for a Sennheiser headphones. So what we can do is if you develop a technology which enhance the hearing, enhance connectivity of Bluetooth, enhance connectivity of AirPods, noise cancellation, active noise cancellation, we could just copy it and paste it onto our hearing aids or implant divisions. Then what happens is on people who's having a hearing loss, their performance can go much higher or their quality of hearing can go much higher. Now think about a hearing aid or an implant, like you hear like a Sony or a Philips headphones scenario, or the same implant or a hearing aid now sounds like a Bose high quality audio signals. And that differs a lot. And that's the old saying goes, the better you hear, the easier you understand, and more clearer you hear, the more clearer you speak. And that philosophy definitely continues along with it. Now, in this arena, we also hearing element for the patient. Today's technology has developed to a level where if a patient comes to you with a deafness, and then they give you the same complaint, right, irrespective of the age, the gender, they come and tell you that my child cannot hear or I cannot hear, and you recommend them a hearing aid or cochlear implant. There, what we do is basically we enrich the functional element for those recipients. Means ear is a hearing mechanism. The idea or the function of the ear on the child, you can make the child hear. Now, hear doesn't mean that you make the child understand whatever is spoken, right? Like Dr. Mira was talking, I heard everything in Bahasa, but I understood a little bit of it, though I heard everything. Because the hearing is a brain function and listening is the ear function, which we restore. So the functional benefit is definitely being restored. And when you start hearing, and with all the therapy and other rehabilitation, you'll make the patient a social, means they can communicate with another person. Now, most of the time, in let's say 10 years ago, we used to stop there, saying that, oh, now the child can hear, now the child can talk, or an adult can hear, they can talk, and we stop there. But now that's something we want to rethink what we can do. We want to empower them to make it more of the emotional element, which means if you go to Dr. Mira Clinic and take a child and ask a simple question like, what's your name? The child will tell you the name and look at the mother for a confirmation that the child gave the correct answer. And that's not empowering. Now imagine the child goes out to a school, to college, when the child become a teenager, they start dating, they want to get into a job and the career development. You don't have this confirmation or help from somebody. So we want to make them completely independent and empowered, so they are an independent entity in the social culture. That's something we definitely want to make. The reason being, the listening needs of those people are different, right? In your clinical practice, you'll see a very young baby of 1 year old coming in and telling that I cannot hear or my child cannot hear. You can have grown-up kids, teenagers, adults, geriatric population. Then what we do is the complaint is the same, but the solution is also the same. You put the same implant, same technology for them, wherein we want to think differently and say that, oh, their listening needs are different, right? A child want to develop speech and language. The adults want to maintain. The listening environment for a child is cool. For an adult, it's more of the office scenario. For a geriatric, it could be mosque or anything else. So how do we develop technology and help these people through their listening needs? And that's something we definitely keep in mind where we develop. And of course, cochlear implant is not a very old technology, I would say, almost around 30 plus, and we've been developing different technologies over the past to cater to those technical demands. And today is a world where you see all the video, people talk like a normal individual, and that happens with these advances in technology. From the technology standpoint, if you really talk, I'll let it change. Now, if you look at the hearing journey of a recipient, again, Dr. Mira did address this as well. You'll see that there are two options. If somebody being presented to you with hearing loss, be it severe or profound hearing loss, it's not changing. It means it's auto-changing. Okay, so it automatically, so we see that, we have two options. One is the hearing aid or a cochlear implant. Let's not talk about hearing aid. You know what a hearing aid would benefit. Like we said about the headphone scenario earlier, when you give them a better quality hearing, they tend to understand it more clearly and tend to produce more speech. Now, how does a child understand speech? It's not that nobody's teaching the child, right? A normal hearing child, say the first word like mama or whatever, the language is around the age of 1. Maybe at the age of 2, they may make a first proper sentence. Now, who's teaching the child how you frame the sentence? And nobody's teaching. The child is listening and hearing what others are talking, and then they talk out to the public and then getting it done, called the incidental learning. Then that technology is required to make them to hear so better. Like the Bahasa that Dr. Mira was saying, the Satu Dua I learned, nobody taught me. I just heard somebody talking and I thought, oh, okay, Satu means 1 or Terima kasih means thank you. I learned it incidentally. The same applies even for a hearing person. Imagine if I didn't hear well, or somebody who having a speech issue, I would hear it differently and I would say it differently. and somebody has to correct it. So that incidental learning makes a big difference in those technology. And the better you make the child hear, the better the child become great in the outcome. And that journey continues. That journey goes through a hearing aid phase and then goes through a cochlear implant. It depends on the degree of hearing loss the child has. I'm not getting along with this slides. Okay. So if you go back and Google the guidelines, like, who is a candidate for cochlear implant, you will definitely see guidelines from FDA, from TUV coming up and showing you different guidelines. And that's not something I want to talk about. What I want to say in this is the guidelines are, as you know, just guidelines. These are not like gold standards. So always remember there could be borderline candidates, and this candidacy keep changing, but the guidelines don't change that often. All long ago, you will know that people say that if you put a hearing aid, the child get no benefit, then you put a cochlear implant. This was the case around 20 years ago, and then now we don't do that. Now, we do even child with better hearing implanted. So I would say we always now, recently in the last at least 2-3 years, we follow the guideline of 60-60. Means if your hearing loss is more than 60 dB, consider cochlear implant. I'm not saying that you should, maybe you should, consider cochlear implant, or your speech scores with a hearing aid is less than 60%, you should again consider cochlear implant. So the best option is to understand this 60-60 rule, which will help you gain or recommend the correct option for those recipients. Most of the time, we stick to the audiogram, and audiogram is the most, most used measurement tool, and I would say most underrated in that element, because audiogram give you an idea about their detection ability. It doesn't say anything about their listening capacity or the understanding capacity, just give you a rough idea about the ear. So we'd say about 70 dB or more, but there will be a lot of other varieties of sloping hearing loss, racing hearing loss. So always remember these borderlines and outliers in those speech and hearing development for those recipients. And of course, it's a multidisciplinary role which involves in the huge success of cochlear implant journey. Now, speaking on the technology of cochlear implants, there are two things we should understand. The cochlear implant, as you know, comes with two parts. One is the implant that you surgically implant inside the ear, and the external speech processor that you keep in. In the implant, again, it's very important that we select one with a good amount of technology to help them to hear the sound. Now, the idea of any implant is to make the child hear, right? Now, what do you want the child to hear? You don't want the child to hear just speech. You don't want the child to hear just in quiet environment. Now, the sound is a very complex, complex signal, especially when you talk about music, when you talk about speech and noise, it gets all the more complex. Now, how do we look into sound? Let's look at a photograph. You see a lot of cameras in this room. Let's imagine I take a photo from this room with a 10 megapixel camera and a 200 megapixel camera. That's represent your spectral resolution, or like whatever megapixel you have. The angle, the wide angle that I can capture shows you something like the range, how much range you can capture. The wider, I capture everyone. If I have a very short range, I can't. The zoom in function would happen. The most is a resolutional element. Now, the big difference between a 10 megapixel and a 20, even with 10 megapixel, I can see all of you there. I can actually see everybody's faces. I can say, oh, this many people attended. This is what it is there. But imagine if I start zooming. I see somebody writing some notes. On a 10 megapixel, the moment I zoom, it gets completely blurry, right? I won't be able to do it. But in 200 megapixel, you keep zooming, you can still see the clarity. The clarity is restored. Now think this in terms of a sound. Means in the music, if I ask you, can you detect there is a piano being played or a drum being beaten? How do you able to listen? If you hear that clearly with that range. The same applies to hearing, and that's a good analogy to understand these three basic elements. If you code well, you can give the sound to the ear in a very high resolutional element, which is number good one. Another feature which you again want to keep in mind is about the magnet. As you know, any cochlear implant will have a magnet inside to attach to your headpiece. And that magnet is good, we need to have it. But also another problem comes along with the magnet whenever the child need to go an MRI. It's very, as your doctors, I don't need to teach you MRI and then the effects on it on any magnets. So now imagine you have one or even two implants put inside with two internal magnets. There could be catastrophic issues if you have a magnet inside, for which we developed a technology. In ideal scenario, if you look into any implant magnet, it's being divided like in the diametrical plane into North Pole and South Pole. So what we have done is we put in these cylinders inside which rotate in a 360 degrees on axle. So we put it on a non-friction plate so this magnet can rotate. And also within these magnets, these cylinders, these are also being polarized into North and South Pole. So this also can revolve. So as a whole, this can rotate, and as individual cylinders, it can revolve. So when you make both in two-dimensional plane, you make a completely three-dimensional movement. It's act like a ball. So it can rotate and it can revolve. So if the magnetic flux keep changing from any direction, it won't have any effect. It's zero effect. So then we could proudly say that, with our implant, you could actually do approximately even more than 200 MRIs, no magnetic issue, there is no deterioration in magnetic power, and no pain. That's something pretty evident. It's see the resolution? This is exactly, I said, the blurry. There's not a high definition projector, so you can't read it. So you can do even 200 or more. So it doesn't give you any pain. There's the only implant available which has an FDA claim of pain-free MRI a number of times. So the patient walk into an MRI room just like a normal person, remove this processor, do MRI to any part of the body, no head alignment, nothing required, no bandaging, and then walk out like a normal person, and the MRI is done. If you ask your radiologist, it's a very easy brainer for them. One of the great advances we have. And both the implants are molded into two electrode types, perimodular, which is like sitting closer to the modulus of the cochlea, and a lateral wall sitting away from the modulus, depends on anatomical considerations or surgeon's choices. So that's the implant that we come up with. We also have a new platform called the Marvel platform in terms of the external devices and technology, which help the child to hear and understand the signals, and the signal being processed and all that element happens in the external speech system. Now, when we talk about the external speech processor, we also introduce the AI feature to this. Now, we are in a world of AI, right? Everybody uses ChatGPT, everybody uses, I don't know, Perplexity to check. Even you have written whatever is correct, you just type it in to see if everything is correct once again. So the same AI applies even for the hearing, which means when you clean all your signals, can you ask AI to double check and double verify and clean further into those environments? And then we definitely use AI to clean those signals. The reason being, let's look at a child. When you look at a child environment, the child always is not in the same environment. Even in this room, I'm talking to you, predominantly my voice is the loudest. You go out, it's noise. You go to the lobby, it's more noise in the lobby. You go out, it's traffic noise. So you can't tell the patient to change the settings every time you change your listening environments, right? And even in this room, now I'm talking. If I don't talk for 1 minute, all of you start talking, it becomes a noisy room. Again, the listening needs changes. So if you look into a child in a classroom or in any activity, there's a big change which is happening within the system. And also, interestingly, it's not one environment, which is environment specific. The AI is not doing a switch. It does something called as a blend, which means, think this room, I would classify this room as a speech in quiet, right? Relatively quieter, and my speech is the loudest. But then think again, is there noise? You can always hear the fan noise. You can hear the AC noise. Somebody is typing, you can hear the typing noise. You can hear somebody writing. And we want the child to hear, remember that high fidelity sound I said, we want them to hear. So this doesn't cut off the noise, it blends. And you have music in the background, it works 20% music, 80% speech, 20% noise. You can always blend in different scenarios, make it all the more natural rather than switching from one feature to the another. So that really helps in our algorithm to identify all this and move from one scene to the another automatically. And within one classification, you can blend different listening modes. And this is not changing. So I don't know. Subhan? Subhan, can you help? Yeah, go to the next slide. Next one. So that helps you to seamlessly understand in any listening environments. Go next. So then again, we are in the world of connectivity. Imagine all of you, like, 10 years ago, maybe 10 is a short time, let's say 15 years ago, nobody had a smartphone, right? I also had the Nokia and Blackberries, and nobody had the smartphones. And today, if you leave your phone out for 10 minutes, you feel like, oh, I'm missing something. Now think the Gen Zs or the teenagers, and I'm not saying we are old, we all are young, but let's say still young. And the more younger ones, they're more pertaining to that, right? There was a recent study I was reading. The people below 20 years blindly believe what ChatGPT says. And people above 20 years, whatever ChatGPT says, they will also think, is it true or not? And now that philosophy is changing, right? The same applies. You want to be connected to your laptop, to your phones, to any mobile phones. Again, in this room, we must be using at least 15 different brands. And in that brands, different models, right? So then we open it like an open network. We do not restrict them that they can use it only with some certain phones, certain models, even within, let's say, Samsung or Apple, certain levels. No, we open the platform. Like even if you use an old Nokia with the Bluetooth to all the way up to a Samsung Fold or an Apple 16 or 18 Pro, whatever, you can still use it. It doesn't make any change. So we keep it like an open platform for them. Suman, it's not working, man. Can you go next? And we were the first one to introduce even the waterproof solution. Now remember, our idea is to make the child be like normal. We don't switch off our ear when we take a bath or when we go to a swimming pool or when we are in the beach, right? But imagine your patients, you give them expensive hearing aids and implants and you tell them, but don't use it when it is in water, when it is raining, when you are sweaty, when you are in the gym, when you are hiking. But we take that away, wherein we have our own, we were the first one to introduce a waterproof microphone. It's not that we put this implant or the processor in a plastic cover. No, that's not the way it works with AB. We have a waterproof microphone, which is exposed in water. It's a hydrophobic membrane, wherein they can do any activity. So it's 100% dust-proof and waterproof, making them a completely normal individual in the environment. Subha, can you see? Now, remember I told about the adults and pediatrics. Look at a condition like in Indonesia, the money is a big issue. So ideally, you need to put 2 implants for people, right, to have better hearing. But in this country or in developing nations, we do not have that option. So what we do have is we have specially designed hearing aids for adults and pediatric, which is designed in a way to work with the cochlear implant. Now, this is not a regular hearing aid that I'm talking. These are specially designed hearing aids for adults and pediatrics, which is designed in a way that that hearing aid will work with cochlear implant, and the hearing aid would function more like a cochlear implant because we do not see a right ear and left ear as separate ears. We are talking about the total hearing. And this system is designed to work together. And in real time, they will be able to send audio signals between one device to another, which means, let's say if you put 2 implants onto the processor, they can talk to each other. This processor can send audio signals. I'm saying talk, it's not some signals, or full audio bandwidth in high definition can send from one processor to the other and this one to the back. Or if they use bimodal, one hearing aid and one cochlear implant, they can still talk to each other. So we believe that you need that 360-degree of hearing rather than 2 ear working as 2 individual ear, wherein you can do a lot of functions. When you get a phone call, you hear on both sides, be it implant hearing aid or implant. You can do a lot of changes. The most important one is this one called the stereo zoom or the speech and noise we call, wherein in an extremely noisy situation, it can send the signals between each other, and using these microphones you can listen to the person in front of you, even in an extremely noisy situation, wherein they hear much better in that situation, which is a pretty good tool that we have in our system. One another feature that we built in is called the remote programming. Again, look at a country like Indonesia. It's so big, right? Let's say you have one patient coming in from Solo or Semarang or Bandung, getting implanted, and then they go back. Now, if they need some programming, the child need to come, the mother need to come, the father need to take leave, even the siblings has to leave from the school to come in and bring them for programming. So what we did is we introduced something called remote programming. And now this is not remote adjustment, wherein they can make some adjustment. This is a 100% programming, which means if a patient sit in front of Dr. Mira versus if the patient sit in Bali in the beach, it makes no difference for Dr. Mira. You can make all the changes you want and in a more realistic environments. It makes zero difference if the patient is here in the hospital versus sitting outside, and their smartphone, a mobile phone, will work as an intermediate device. What they need is just a good internet connection, and that's it. I'm sure internet is widely used in Indonesia. With a 4G or a 5G, you're pretty much done. And then Dr. Mira can make any changes they want in a very realistic environment, which is very good. We were really happy. We had one patient say that whenever I go to a restaurant, I cannot hear. And when you sit in your audio room, he can just tell you in that restaurant, you don't know what restaurant it is. Now we can make them sit in that restaurant and make changes to that real life situations. Makes it a very big difference for people who live in countries like big countries. So to summarize, the basic idea with us is, we want to empower those patients. So be it improve their quality of life, self-esteem, daily activity. So at the end of the day, what we are trying to look is to make them an active member in the society. Usually I am more of a scientific guy. I don't like to talk too much about studies, but I thought I'll show you one last study. Now, this is a study done. This is a speaker, 11 of them, with a bimodal configuration. Means they are profoundly deaf and implanted in one side and hearing aid on the other side. All these speakers in gray color. It's just changing and I'm not changing it. These speakers in gray color are making noise. And this is not an animation error. The one in the front, the red and the gray, are also making speech and noise. Means even from the front, you have speech and noise coming in. It's one of the extremely challenging situations. So the noise is all around and the speech is coming from the front. Now in that situation, we started calling these people with bimodal configuration and started activating technology by technology, and you see a big improvement in performance. Now this means lower the better. Now, in this situation, what we did is we want to call people with normal hearing and check how they will perform in that situation. To our surprise, by activating all these technologies, so when can you just go on? Is it changing? Oh, no, before. Now you know this is my last slide, so so you see the normal hearing people, some of the normal hearing people actually, or let's say most of the, or all of the people with profound deafness actually scored almost similar as some of the normal hearing people. Now, which means, with the amount of technology, even in challenging listening situations, even people implanted on one side with good technology can hear as good as normal hearing people. And hear me well, with this the way technology progress, in the recent time, people with deafness, bilaterally profound deaf, actually hear better than normal hearing people in noisy situations. That's like a dream. If I were to tell you this 15 years ago, you'll think I'm joking. But now you see the technology makes you to that level, and that's exactly what we are trying to do to make them hear and make them more independent in their listening needs. Yeah, this is my last slide, and thank you. Thank you very much for listening. Dr. Thank you. Any questions from them? Yes.
Thank you very much, Dr. Ajimsha. Very interesting lecture as always,
Thank
and
you.
magnificent to see advanced bionic technology from the electrode to magnet, AI with autosense and every detail that is very advanced. So is there any question from there? Please.
Sure. So thank you very much for the presentation. I reckon it's very interesting. What I'm most interested about is the environmental blending that you say. I mean, some of the patients with older model, I reckon some of them complains about if they don't have enough environmental blending, meaning background noises, some of the voices that they hear can sound a bit robotic, right? So with this technology of environmental blending, what I was trying to figure out is how much environmental blending is being put into the hearing in terms of, I figure if you do a lot of environmental blending, you'd sacrifice speech recognition. So is there a balance between both of it so that the sounds still sound natural, but it's still recognizable as well?
Good point. If you talk about the history point of view, initially we never had the blend. We had like program switcher. So you make a music program and the system detects its music, it's switched to music. It detect quiet, it switched to quiet, but that's very rudimentary. Now, remember, in any signal, the more, like you rightly said, the more you clean, the more you remove, it goes more robotic or more unnatural. Let's call it that way. It's very evident. So what we've done is, okay, now technologically, this analyzed the environment using our 8 microphones every 4 milliseconds. It's a very short time. It keeps analyzing. And it then backseen it 200 times to check how good that signal is. And within that 200 signals, it picks up, which, okay, now 10% is music, 5% is noise, 80% is speech. So it activates 80% for speech, 5% for music to make it more natural. Now, you rightly said, when we developed it, we developed with the help of software in the anechoic chamber, we had the same problem. It was more robotic or mechanical, and the switching was not normal. So we hired around 5 people with a backpack with it's a fact. I have the photographs of it with a recording system, and we send them out, 3 to the kids area and other 2 to the adult area in classroom, in train, like 3 months or 6 months, they were just recording the samples and switching to make it more natural and ideal. Even have a video of them standing just in the middle of the Autobahn German highway in a bridge. That's it. Just to see how when the car passes through, how much the tire noises comes in to make it more natural. It's a very valid point. And then, yes, we factored in. That's how we decided that optimum level is about 4 millisecond analysis and the 200 scenes you need to make it more natural. And it should not also feel the patient that it is switching. It should be like more of a smooth transition. So that, yeah, that's the optimum time we took to do it. Now, saying that, in the software, if you go to your advanced features, there's an option where you can alter it a bit. Like you can make it like 8 millisecond if you really want, especially from old people, with geriatric population, they don't want this super high tech. You can delay it, though, if you really need it. But ideally, a 4 millisecond and 200 setting will definitely take it away. But very interesting point. Thank you.
Thank you. Thank you very
Thank
much.
you very much.
Thank you.
Any
Any other question? Regarding the AB technology? Maybe not all of you are very recon about the AB technology. Yes, please. Oh, no. Okay.
Yeah.
Dr. Mira, maybe? Dr. Harim. Dr. Harim, maybe? Or Dr. Angga? Dr. Angga?
Thank you.
So it's very clear,
Thank you
actually.
very much.
Thank you very much, Dr. Ajimsha. So, thank you very much. And now we will move to the next lecturer. That is Ms. Janani Jeyaraman, M.Sc, certified AVD and speech and language pathologist, audio advanced bionic, Southeast Asia. So please, Ms. Janani. So welcome. Welcome.
Okay, morning everyone. Thanks for having me. I have a real bad cough, so bear with my voice. Okay, sometimes if it gets worse, maybe I just take 1 minute break and come back. What am I going to talk to you about is not about technology, because technology goes above my head. So I try to understand it in small terms, and the small terms is what I'm trying to share with you today. So I work for rehabilitation of cochlear implant users. And today I want to talk about how to maximize the technology and get good listening and spoken language outcomes. So we implant the kit for them to listen and talk, right? So how to make it better, how to get maximum from whatever is available. So you know that child is hearing from the pregnancy time. It's like around 3 months, the child's inner ear is developed. And it's not only the structure, right? The child starts to listen to body voices like breathing, heartbeat, and then even voices outside after like 6 months or 7 months. So that's how when the child is born, we say, yeah, looks like she recognizes mom's voice. Looks like she recognizes the music I used to hear. So we say it because the child is hearing those vibrations or frequency even inside during the gestational period. So a child who is born starting for hearing from day one and even from days before. But when you think about a child with hearing loss, they are not hearing from day one. They are hearing with a gap when you give them access to hearing with a hearing aid or a cochlear implant. So let's just keep that thought in mind. So once the child is born, he starts hearing, and how he develops further listening and language. It's based on the experience he gets. If he's in a house where people are talking more, then he picks up words more. If he's in a house where people are exposing him to more and more adults, he's getting good language model. If he is taken around to different environments, go for shopping, go outside, go to the park, then he gets more experience. And from that experience, he develops his neural structures. Am I right? Yeah. So when I say about development or experience, what do we mean? You play with ball with a child, he gets different senses. Ball is soft, ball is colorful. You can throw the ball to someone. When you throw and catch, there is fun. You interact with the ball. Ball has a name. So all this happens during an experience and it gets stored. And how it is stored? It is stored as neural connections. And these connections happen faster in the early period, before 2 years. And after 2 years also, you can still learn, but the most optimal time is before 2 years. It's faster, it's efficient, it's quicker, right? And even at 70, you can learn a language, but it's not that fast. Okay. So timing is very crucial, even for kids with normal hearing, kids with hearing loss. So how I said how to maximize outcomes after cochlear implantation. You need to remember the 3 points. I think both the other speakers highlighted on it. You have to have early identification. You know the 136 rule for early identification of hearing loss. You have to give appropriate device, which means based on the hearing loss, you need to give them either a hearing aid or a cochlear implant. Remember, from day one and before, a child with typical hearing is getting listening experience. And our children cannot lose a day. So as professionals, we keep trying to tell them about the emergency to get listening access. Yes. And then you have to have early rehabilitation. We call it AVT. So I'm just skipping this slide. Yes. So what you need in technology as a layman or maybe as a parent or as a rehab person, how I understand technology. I need technology which gives me, sorry, it's a bit slow. Not having an early start. So for me, from technology, what I see, like Ajimsha was saying, if my child is going from one situation to another situation, speech is very fast, right? People talk together, people talk taking turns. I don't want my child to miss out on some information. So as he moves from one environment to another environment, he should pick up the signal. So I check if my technology, whatever I'm recommending, does it have that capacity to make these shifts, help them hear better in every situation with less trouble from the child's end. He should not be changing a button. It should happen automatically with AI, with digital technology. So is it happening? Then I'm recommending a good technology. Does it have connectivity? It's not always about only listening. It's about lifestyle, right? You need quality of life. The kids nowadays, they are connected to Bluetooth. They need to connect to an online session. They hear to music along with their friends. So it's not just about listening. Is my device also giving them the lifestyle equivalent to their peer? So that's one aspect you can consider when you recommend technology. It's slow. And pediatrics, they are very active, toddlers. Okay, so it will fall. Does the technology or the shape of the technology, does it help in retention? So when they engage in sports, Are there accessories to ensure the device stays on? So these are all some factors we discuss with the parents. So the hearing technology, you fix it for the lifestyle of the family, the needs of the family. Every family is different. So you talk about that. And then as rehab, that's what we do when we deal with technology. Does it fit this family? Which feature fits this family? That's the engagement we do. And to maximize outcomes, it's not enough if you have one hearing, two ears are very important. Imagine I have to do this whole presentation, but just standing on one leg. I'm going to get tired. Okay. Imagine you have to listen to me. My voice is not great today. It's a bit of an effort you have to do to listen to me. So that's additional effort. And a child has to sit in the class and listen from morning 9 to 2 o'clock. And the signal is not good. The effort is going to be more. So that's why giving 2 years is very, very important to reduce listening effort and then to improve speech perception and noise and to do localization. And Ajimsha was telling, I learned some Bahasa. And nobody taught him. He just picked it up because he has 2 years. So incidentally, spontaneously, he's picking words. And that happens in a child when you give them 2 years, the probability is more. Okay. And then remote microphone. Imagine, oops, I don't know how to go back. No. Go back. Okay. So imagine you have a circle around you. It's you? Yes. So imagine there is a bubble around me. Within 3 feet, in quiet situation, if I talk, whatever I talk will make sense to them. But beyond, they cannot. So in classroom, it's beyond 3 feet, right? And when the child has hearing loss, he has the surly take him nearby and shout, then he hears. So the listening bubble is smaller. When you give cochlear implant, the bubble becomes bigger. But when the child goes to the next situation where there is noise, where there are more people, you need the bubble to be bigger, right? It's not 3 feet, it's not enough. So that's where the remote microphone comes in. Remote microphone, Roger or FM, it helps you hear across distance and across noise. So when your child transits from the early ages to school age, it's important to reconsider about Roger systems or remote microphones. As I said, this is for maximizing outcomes. Okay. Oh, money part is always there, but this is what technology can offer you today. And then Bluetooth technology, we know now we use, how many of you use Bluetooth daily? Yeah, Subhan, yes. Even now, maybe he's listening to something, I don't know. So yes, even teenagers, they are into Bluetooth, they are walking with their headphones. So the lifestyle, as I said, it's important you need Bluetooth connectivity and advanced bionics. He already summarized. You can connect directly to the stream signals. Why it's important? For teenagers, it's important. For children, it's important. Even for adults, it's important. Their children are sitting somewhere abroad and they want to connect with them on video call. They love the Bluetooth technology. They can talk to their family easily. If they are listening to podcasts now, they are seeing their mega serials and soaps, they can connect directly without disturbing anyone. So that's where lifestyle, it's very important to have connectivity. And technology is amazing. I started in days where we were having analog hearing aids, and then we were sitting with a big drum to see whether the child hears. And then it transformed to digital, then cochlear implant, which processes speech, then now music, then AI. You know, the whole journey has been amazing and it happened in a short time. But even though technology grows faster, you still need to teach the child. So that's why rehab is important. What do we teach the child in rehab? Technology just opens the door. Sounds all go in. You all listen, right? இப்போ நான் அப்படியே தமிழ்ல பேசிக்கிட்டே இருந்தா உங்க யாருக்கா புரியுமா? புரியாது. because you are not trained to understand that language. You didn't pick up the code of my language. So to help you understand that sounds carry meaning, you need to have rehabilitation. So what do we do in rehabilitation? Oops, So first we help the child understand. First, wear the device. A child has to wear the device minimum 10 to 12 hours. Only then it becomes beneficial. If he starts throwing the device, not so useful. So the first job of rehabilitation is to ensure child wears the device. So now they are connected to the world. And then my next goal is to make sure that they understand there is sound. Okay. Imagine there is a mobile phone ringing now. What do? Pick it up, because you have to listen to sound and you have to react to that sound. So if you give a good cochlear implant, sounds are going in, the child says, yes, I hear, but he doesn't go and open the door. Not useful, right? So the rehab first job is to help them react to sound and respond to sound. And for that, how do we do it? We use small strategies. When someone has to listen, what do? What do you tell them? Listen. Exactly. Very simple, natural strategies. We have to tell the child, listen, pay attention. So this strategy, we have to communicate it to the parents. We have to ensure parents does it all the time so that the child develops the listening behavior. I'm just saying one strategy, like, you point to ears and you say, listen. If your child is not listening, bend down and say, listen. Okay. So these kind of tips and strategies is what the rehab person works in the initial 1 month to help the child connect to sounds. Okay. Can you play the video?
Iya, ada suara ya. Kita
She says, listen.
Iya, dengar. Iya, ada suaranya ya.
I goes big.
Ada
She
suaranya.
listens to the
Kita buka
sound.
dulu. Oh, suaranya dari mana? Gak bisa dibuka, Zara. Kita tutup lagi.
What do we help the
Oke.
parents with? Oh, suddenly my voice is better. What do we help the parents with? We teach them that those are the listening behaviors. As professionals, we know her eyes went big. Okay, she was so happy to play with the toy. But a parent is always maybe trying to look for when my child will talk. They miss out on all these behaviors. So we try to also guide them that these are the listening behaviors. See, your child is listening to sound. You build the confidence, ask them to listen, connect to sounds. Sorry, the first stage. Next slide.
Wah, bagus.
And the next. And doing this in listening. Can you learn a language without listening? Can you speak without listening? Are you sure? You cannot say a sound ah without listening. You cannot see my mouth and talk. So there are ways to talk. You can look at lips and talk, but your speech clarity is not good until you listen and talk. So in listening therapy, what we try to emphasize is, now that you got your cochlear implant, you have access to sound, listen and talk. Okay. Yes. So that's what we do. Next one. Yeah. I'm sorry. Can we go to the next slide? Next one. Next. I don't know. Why are we looping? Okay. So first we connect to the sounds. The child understands there is sound. And in the second stage, what do? We have to help the child pick up language. How do you pick up language? A child has to hear 30,000 words per day. Okay. So we need to educate the parents that you need to talk to the child more and more. Remember, I said about experience. You have to give a lot of language experience for the child to pick up language. So 30,000 words, each word you start learning. If you want to learn one word, you need to hear it 300 times. And if you're playing and you are happy learning something, doing an activity, you learn it in 40 repetitions. Okay, so that's the amount of language a parent has to give. Let's see if this video plays. Yeah. No? It's okay. No? It's okay, we can move. No problem, it's fine. It's okay.
அடுத்து இங்க கவியா அம்மா அடுத்துங்க
They are teaching the word press. No. This one is okay.
very good அது கரெக்ட்டா
The press. Press.
எப்படி எழுதலாம்
நான் பண்ணிட்டேன்
அடுத்து இங்க இருக்கு ஆரஞ்சு எங்க இருக்குது
அது இல்ல இதே கலர் எங்க இருக்கு இதே கலர் எப்படி
அடுத்து
ஒழுங்கா அடுத்து
அடுத்து பை பை நீ பண்ணியா ஆரஞ்சு
Repeating the words again and again.
இதெல்லாம் சேமா இருக்கும் உனக்கு இத பாரு சேம் இதடா இங்க பாரு பிங்க்
So what they did here, repeat the word again and again. Did you catch the word? So that's when you don't catch the word, we say listen and say it again. Okay, so you keep doing it. In play, we do it because, as I said, from 300, we can reduce it to 30 to 40 repetitions. So that's why we don't sit and teach the word. We play with the child and then we try to teach the word to the child. So now the child hears the sound. He understands the sound, picks up the vocabulary, and then
Clap your hands.
he has to talk, right?
We're gonna wait. If you're happy and you know it, clap your hands. If you're happy and you know it, then your face will surely show it. If you're happy and you know it, clap your hands. He's like, I'm not happy. Oh, he's thinking about.
So what they are doing, simple things that everybody does. I want you to talk. So what I do, your turn. So I put a hand cue. I look at you. I look like, yeah, I want you to talk. So those are simple strategies. You help the child to make them talk. So now your child listens, understands language. He can talk. Okay. Let's see. As I said, so sorry, it's not in my control. It's not in his control. This one, yeah. So what we do here, from early time, we start introducing music to them because earlier the technology capacity was not there for music. But now technology is so good. So you start inducing music into your sessions from early times. Okay, and the children starts appreciating music. Yeah. Next slide. Yeah. We can go next.
Satu dulu ya, Mi. Kasih lihat satu, Mi. Satu. Coba minta dulu. Mau. Coba. Mau. Zaki lihat Mami.
Zaki mau?
Iya betul.
What do they do here? They say, you are talking now well and good, but now I want you to talk in words. And I tell you the words. So don't just grab, put your hand out. Now, if you know to put your hand out, I tell you the word mau. So you please ask the word and get your things done. So you link it to language, then to speech. Okay?
Mami, satu dulu ya.
Next one. I'm just skipping few because it's little theory. Okay. Yeah, we can play this. Watch this video. Okay.
Vici, चले. Ceri. Ceri ini. Ceri ini. Okay, பிச்சாச்சு. இப்போ என்ன பண்ணோம்? அலசணும்.
So you see there. So she's repeating the word again and again, right? So it's correct. But what's happening wrong? You're not sure it's happening through listening. Not even once she said listen, right? So I told you listening therapy after cochlear implant is about connecting listening to language and speech. So here it's visually being taught, pitchy, but the child is not told to listen. So that's where we use strategies for helping them to connect listening to speech. Okay. Move on. So that strategy is called auditory sandwich. You put in listening, then you give visual cue, then you put it back in listening. In the next video, they are asking a child to make the sound f. Okay, because it's slow, I'm giving the introduction to the video and the child doesn't say it correctly. So you see the therapist, put it in listening, come in front, give a visual cue, and then go back and put it in listening again. Yes. He says, shh.
Ini juga saya di rumah sebenarnya bingung, nggak tahu seperti ini caranya.
So what we are doing is insisting to the child that you have to listen and say it back. Okay? You can pause. Can you repeat the word sounds I'm saying? Ma. Pa. Mapa. Pama. How are you sure it's not Pama? So in the visual cues, you get only certain amount of speech information. Only when you put listening, the information becomes better, right? So that's where we talk a lot about listening. And once your child picks up to learn to listen language, then you start working on memory. Can you point to crocodile? Can you point to crocodile and umbrella? Can you point to crocodile, umbrella, and that bear? Can you show me banana, school, ladder, and chair? So you increase their memory. Why do we increase their memory? Because we talk in sentences. So a child has to hold the sentence or the words for certain time, think about it and understand the meaning. So for that, you need to increase their memory. So you work on memory like that. Then you work on, can you show me the cow sat on the ship and went to the school in a school bus? So you make it little more difficult. So you work on memory, you work on sequencing. And then you work on sentences. Can you put the man in the middle of the sea? Okay. Can you put the boy under the red umbrella? So you tell them some commands where they can process language. And then you ask them to talk. Now that you can understand 2-3 words, now I expect you to say 2-3 words. So if he just says Mau, I want him to say, can you give me the red car? Mau mera red car, mobile, I don't know, something like that. So you help them to understand more words. I show you this video. So what we did was we connected to sounds, we connected to language, we connected to communication, we connected to speech, we connected to even memory. And then now we are connecting to cognition and processing. So instead of just saying, can you show me cow? I can say like, can you show me an animal? Can you show me something you drink? Okay, or I can tell a story and ask her, what did the character do? So you process on the language. So that is the last stage. Okay, and that's where I just want to share this video. I hope the audio works well.
A television set costs 582. A refrigerator is 100 more expensive than television. How much the cost of refrigerator?
Is 682.
Okay, so it's a max sum. They are saying a television costs this much, a refrigerator costs 100 more. So what's the cost of the refrigerator? Everything through listening, not visual, because the child was benefited by early implantation, early rehabilitation, and early audiological management. Okay, does it make sense? So that's the stage where we leave the child in the end, where she can manage conversation in a group of 3 to 4 kids. So they are ready for mainstream situation where there will be group lessons and other things. So this is an overview of auditory verbal therapy. So this takes for a child who's implanted early around 2 years to 3 years to catch up with their peers. If they are implanted a bit late, then there are some delays and it takes a little bit longer process. So that's why early implantation is very important. And with that, I conclude my talk. Thank you so much for your patient listening.
Thank you, Ms. Janani, for your amazing lecture and highlight that it's very important to choose the correct technology to support the habilitation. And also the step of habilitation is very clearly explained. Thank you very much. And now, is there any question from the floor? Yeah, please.
Yeah. Okay, thank you, Dr. Ray, for the opportunity to ask a question about how important the act of the family for the patient or the child or the kids with the implantation to prognosis of the patient for the presentation. Thank you.
So you have something called factors that affect outcomes. And in that, the top factor is family. It's like growing your own child with typical hearing. How important is your role in growing your child who has normal hearing? Multiply it by some more times, like 50 times or 100 times. That important is parent role in rehabilitation, because I will maybe see the kid for weekly 1 hour or maybe weekly 2 hours. Rest of the time, the parent is supposed to give the experience for the child for language and listening. And the normal issues come is whenever the diagnosis of hearing loss happens, the couples go into some different mindsets. One accepts the hearing loss, one doesn't accept the hearing loss, one becomes supportive. So marital issues take some time to stabilize after the diagnosis of hearing loss. So that also affects the progress in a child. Does it make sense? Yeah.
Yes.
Yes. So parent role is important. Generally, mothers buck up across the globe, but there are lovely fathers also who contribute to the rehab journey. But it will be nice to have more fathers. Yes.
Thank you.
Okay, thank you. Is there any more question? Okay, if there's no more question, we will move to, I think, company profile from AB. Please. So we have a little bit for closing. Yes, from Nobel, please. Boleh dalam bahasa Indonesia.
Selamat pagi, salam sejahtera semuanya. Perkenalkan saya Abdul Aziz dari Nobel Audiologi Center. Di sini saya perwakilan perusahaan kami, di mana ya perusahaan kami bernama PT Nobel Jaya Mandiri atau Nobel Audiologi Center. Kami adalah perusahaan alat bantu dengar, salah satu yang terbesar di Indonesia, di mana perusahaan kami sendiri sudah memiliki yang namanya legalitas ya, di mana kantor kami berpusat di Grand Orchard Junction, Kelapa Gading. Jadi nanti mungkin dokter-dokter yang mau visit ke kantor kami pusatnya di Grand Orchard Junction, Kelapa Gading. Next. Ya. Oke, ya. Loading dulu ya. Oke, kami perusahaan pusat alat bantu dengar sendiri dari Nobel memiliki visi diantaranya menjadi, boleh dibantu di next di sana aja ya, kayak ini agak lama. Oh, oke. Ya, menjadi pusat audiologi bertaraf internasional, ya. Ya, dalam penanggulangan masalah pendengaran ya dengan memberikan pelayanan yang terpadu dan terakurat ya, di mana kami sendiri memiliki layanan yang lengkap mulai dari pemeriksaan audiometri nada murni sampai pemeriksaan audiologi untuk pediatrik dan pemasangan teknologi pendengaran. Di mana untuk mencapai visi ini kami memiliki beberapa visi yang diantaranya iya, memberikan pelayanan audiologi yang terpadu dan terbaik dan memberikan solusi yang terbaik juga untuk mereka yang mengalami gangguan dengar dan ikut serta memperbaiki ya, meningkatkan kualitas hidup orang-orang dengan gangguan dengar. Dan kami juga misi utama kami salah satunya adalah membangun SDM kami ya yang profesional dan berdedikasi dalam pengembangan ilmu pengetahuan di bidang audiologi dan akustik. Ya, kami sejak tahun 2014 memiliki cabang-cabang yang sudah tersebar di Indonesia, bahkan jumlah cabang kami sudah tersebar di 32 cabang di seluruh Indonesia termasuk Indonesia Timur. Ya. Ya. Yang berikutnya kami sebagai pusat alat bantu dengar yang memiliki konsep layanan one stop solution di mana semua layanan terpadu itu disediakan dalam satu tempat. Mulai dari layanan pembelian atau penjualan instrumen pemeriksaan pendengaran dan keseimbangan, layanan pemeriksaan pendengaran dan keseimbangan juga. Berikutnya juga ada layanan pemasangan teknologi pendengaran baik itu alat bantu dengar dan cochlear implant atau implan cochlea, dan layanan habilitasi dan rehabilitasi mendengar pasca penggunaan teknologi pendengaran. Dan terakhir itu ada layanan untuk servis alat bantu dengar dan kalibrasi instrumen. Ya, selain yang tadi saya sebutkan, kami Pusat Alat Bantu Dengar Nobel memiliki beberapa layanan lainnya, diantaranya memiliki layanan free field test atau evaluasi pendengaran, ya pasca penggunaan teknologi pendengaran. Berikutnya ada layanan optimalisasi fungsi alat bantu dengar yang tidak dimiliki oleh semua pusat alat bantu dengar. Ya, dan di mana berdasarkan WHO bahwa pusat alat bantu dengar atau hearing center yang sudah memiliki layanan optimalisasi fitting alat bantu dengar yang disebut dengan REM atau Real Ear Measurement, ya, itu sudah masuk kategori sebagai standar emas layanannya atau gold standard. Kami punya layanan tersebut. Dan berikutnya kami juga ada layanan servis alat bantu dengar jika bagi mereka yang sudah ada masalah, ada care maintenance-nya juga di Nobel Audiology Center. Berikutnya kami juga memiliki layanan tambahan atau added value, kami bisa memberikan perpanjangan garansi bagi pengguna implan koklea dari AB, ya. Ya. Kami menyadari bahwa dampak gangguan dengar dapat mempengaruhi ke kesejahteraan yang berkaitan dengan emosional, sosial, kognitif, dan juga fisik. Oleh karena itu, kami sebagai pusat alat bantu dengar ingin ikut berperan dalam meningkatkan atau mengembalikan kualitas hidup bagi mereka yang mengalami gangguan dengar dengan memberikan teknologi yang terbaik dan sesuai dengan masalah gangguan dengarnya yang dilakukan oleh tenaga kami yang profesional. Di mana salah satu pemilihan teknologi pendengaran yang ada di kami adalah alat bantu dengar konvensional. Di mana alat bantu dengar konvensional kami sendiri memiliki 3 model. Yang pertama ada BTE atau behind the ear yang di belakang telinga, dapat direkomendasikan bagi semua jenis gangguan dengar. Dan berikutnya ada model RIC atau receiver in the canal, di mana speaker atau receivernya ada di dalam lubang telinga, alat bantu dengarnya di belakang. Jadi secara ukuran meskipun di belakang telinga jadi lebih kecil. Terutama ini sangat cocok dapat direkomendasikan bagi mereka yang mengalami gangguan dengar high frequency hearing loss. Yang berikutnya alat bantu dengar yang modelnya di dalam telinga atau yang kita kenal dengan custom. Custom sendiri yang ada di kami ada beberapa tingkatan atau level ukuran berdasarkan tingkat gangguan dengar dan powernya. Ada yang completely in the canal atau CIC, ada in the canal atau ITC, dan ada yang ITE in the ear. Ya, kami selain memiliki beberapa pilihan model alat bantu dengar, Nobel Audiology Center juga memiliki beberapa fitur teknologi unggulan yang ada di dalam alat bantu dengar kami. Di antaranya adalah Artificial Intelligence atau AI, yang dimana teknologi ini dapat mengidentifikasi, melacak, mengetahui situasi, kondisi lingkungan pendengaran si pasien atau si pengguna. Apakah ada di dalam ruangan yang sepi, di tempat yang berisik, atau di restoran, atau di lingkungan yang berangin. Dengan teknologi AI ini dapat mengetahui lingkungan tersebut yang fungsinya adalah agar nanti settingan atau adjustment di dalam alat bantu dengar tersebut bisa disesuaikan dengan situasi lingkungan yang mengarahkan utamanya terhadap fokus suara percakapan, sehingga di situasi apapun pasien tetap bisa atau si pengguna bisa tetap fokus terhadap suara percakapan. Yang berikutnya adalah noise and wind block atau wind reduction, di mana teknologi tambahan yang mendukung teknologi AI kami untuk bisa memaksimalkan peredaman kebisingan agar kebisingan atau suara angin itu bukan hanya mengganggu percakapan tapi juga bisa dibuat didengar lebih nyaman, ya. Berikutnya teknologi yang ada di alat bantu dengar Nobel sendiri yaitu memiliki fitur feedback cancellation. Kita tahu dokter ya bahwa pengguna alat bantu dengar seringkali keluhannya berdenging, alat bantu dengar nah ini kok bocor suaranya nginging. Tanpa adanya teknologi feedback cancellation maka alat bantu dengar tersebut akan lebih rentan terjadinya feedback. Oleh karena itu kami sebagai pusat alat bantu dengar menyadari teknologi yang paling penting untuk para pengguna alat bantu dengar adalah teknologi yang dapat menghindari penggunanya dari masalah feedback. Makanya kami menyediakan fitur feedback cancellation. Yang berikutnya, kami memiliki teknologi Bluetooth ya yang dapat menghubungkan alat bantu dengar ke perangkat elektronik seperti smartphone, laptop, ya, iPad dan sebagainya. Karena saat ini di era digital kita bukan hanya mendengar lawan bicara kita yang secara langsung, tapi kita juga sometimes seringkali berkomunikasi dengan lawan bicara kita yang jaraknya jauh ya melalui perangkat elektronik. Dengan penggunaan teknologi Bluetooth ini, mereka bisa terhubung dengan keluarganya, saudaranya, koleganya, atau kawannya yang jauh. Berikutnya, teknologi alat bantu dengar kami juga dilengkapi oleh sertifikat Water and Dust Resistant, jadi lebih aman terhadap cipratan air dan debu. Dan alat bantu dengar ini sangat cocok digunakan di lingkungan tropis seperti negara kita, yang menjadi masalah utama bagi para pengguna alat bantu dengar ketika alat bantu dengar itu lembab. Berikutnya, teknologi alat bantu dengar kami dilengkapi juga dengan tinnitus balance, di mana ini bisa menjadi solusi bagi mereka yang mengalami tinnitus tonal, denging atau dengung yang tidak bisa terbantu mungkin dengan obat atau apa, dengan melalui terapi. Setelah menggunakan teknologi tersebut bisa dibantu dialihkan dengan teknologi tinnitus balance yang ada di dalam alat bantu dengar. Nah, jika alat bantu dengar ternyata tidak cukup untuk membantu masalah gangguan pendengaran, kami memiliki solusi lain untuk gangguan dengar berat sampai sangat berat, yaitu adalah teknologi implan koklea yang berasal dari Amerika, brandnya AB atau Advanced Bionic, dan di mana Nobel Audiology Center sendiri menjadi authorized distributor di Indonesia untuk brand AB, ya. Dan saat ini perlu diketahui untuk di area Jakarta, Jabodetabek sendiri pengguna AB sudah mencapai lebih dari 700 telinga, ya, 700 telinga. Oke, yang berikutnya. Ya. Nah, selain kami memiliki layanan pusat teknologi alat bantu dengar ataupun implan koklea, kami juga menyadari bahwa penanganan gangguan dengar terutama pada anak-anak bukan hanya pemberian alat bantu dengar atau implan koklea saja, tapi juga perlu adanya layanan habilitasi dan rehabilitasi mendengar yang dimana kami memiliki layanan tersebut atau terapi mendengar dan wicara dengan metode AVT atau auditory verbal therapy yang disebut dengan our rehab, ya. Di mana our rehab sendiri itu bisa digunakan bagi pasien-pasien kami yang prelingual atau belum memiliki bahasa. Salah satu contohnya adalah pasien congenital hearing loss dan juga postlingual, terutama bagi pasien-pasien bapak-bapak ya yang sudah menggunakan implan koklea ataupun alat bantu dengar. Bahkan pasien kami yang implan koklea saat ini yang paling tua sendiri itu umurnya sudah 80 tahun ya dan sedang melakukan proses rehab atau auditory training. Ya, ini adalah salah satu contoh aktivitas rehab kita. Kami juga membersamai orang tua pasien dengan gangguan dengar melalui komunitas rehab AVT ya di seluruh Indonesia. Ya, selain itu kami juga memiliki layanan e-audiologi atau audiologi online yang meliputi telekonsul. Jadi melalui layanan telekonsul ini kita memberikan layanan konsultasi secara online melalui website yang bisa appointment, lalu bisa melakukan konsultasi teknologi pendengaran baik itu alat bantu dengar ataupun implan koklea. Bahkan kami juga memiliki layanan tes pendengaran secara online yang namun ini bukan untuk diagnosa tapi hanya untuk screening ya dokter semua ya. Ya. Ya, berikutnya kami juga ada layanan remote fitting bagi pasien pengguna alat bantu dengar. Jadi mereka meskipun jaraknya jauh, rumahnya di mana, misalnya di Ternate, petugas kami ada di Jakarta. Mereka nggak perlu datang ke Jakarta hanya untuk melakukan setting alat bantu dengar. Tinggal buat appointment sama petugas kami, lalu kami bisa adjust atau setting secara remote ya dari jauh melalui aplikasi ya yang terinstall di handphone pasien dan terhubung oleh alat bantu dengar si pasien. Dan bukan hanya remote fitting saja, tapi kami juga ada layanan remote mapping bagi pengguna implan koklea dan AB salah satu-satunya saat ini yang menjadi teknologi implan koklea yang bisa melakukan remote mapping melalui aplikasi. Jadi pasien tuh nggak perlu pakai aksesoris tambahan yang dimana mereka harus beli bla bla segala macam, tapi dengan aplikasi yang terinstall mereka bisa melakukan mapping remote dengan petugas klinikal kami dari cabang kami. Oke, berikutnya salah satu contoh video remote mapping prosesnya seperti apa. Ya, next kami selain ada layanan remote mapping, kami juga ada mapping camp, di mana mapping camp sendiri adalah pendampingan atau monitoring kasus-kasus khusus, kasus-kasus spesial yang mungkin sulit untuk ditangani secara sendiri, tapi juga harus dilakukan bersamaan ya, kolaborasi antar tim. Ya, nah bukan hanya mapping ataupun fitting remote saja yang secara online, tapi rehab atau EVT kami atau terapi mendengar dan wicara kami bisa dilakukan secara online yang disebut dengan tele rehab ya. Jadi pasien misalnya jauh di kota Bengkulu misalnya dan kami belum ada cabang, pasien tersebut tidak perlu harus datang ke Jakarta, ke Bandar Lampung ataupun ke Palembang hanya untuk melakukan terapi mendengar, tapi bisa dilakukan secara online dengan melalui teleterapi yang sudah appointment atau janjian dengan terapis kami atau practitioner kami. Ya, nah kami juga ada layanan online support di mana online support sendiri ini merupakan support dari tim AB atau Advanced Bionic, tim implan koklea kami untuk memberikan support berupa pendampingan, mapping, training, diskusi, sharing session untuk tim klinikal kami agar mereka pada saat melakukan mapping dengan kasus-kasus tertentu mereka tetap update dengan knowledge atau skill yang terbaru. Ya, kami juga hadir di e-commerce, baik itu Tokopedia dan Shopee untuk pembelian aksesoris secara online, baterai, cleaning tablet, dan alat-alat aksesoris lainnya di alat bantu dengar. Nah, kami juga ada kegiatan berkala dari tim-tim baik itu tim implan koklea, alat bantu dengar ataupun tim rehab mulai dari edukasi berkala yang dilakukan secara berkala biasanya sebulan atau 2 bulan, 3 bulan sekali. Berikutnya ada AB Teens Talk, di mana ini acara yang salah satu yang bagi saya tuh menarik banget ya dokter semua. Kenapa? Karena ini kami memberikan kesempatan bagi mereka pengguna implan koklea untuk present. Ya, mempresentkan diri mereka sendiri, pengalaman mereka sendiri di depan umum, berbicara di depan umum. Kita mau menunjukkan bahwa mereka yang mengalami gangguan dengar kongenital ya atau gangguan dengar profound yang menggunakan implan koklea akan mendapatkan hak yang sama, kesempatan yang sama ya seperti itu. Berikutnya kami juga ada layanan membersamai orang tua pasien-pasien kami ya, kita bikin komunitas kumpul bersama untuk program engagement dengan pasien yaitu Family Fun Day yang diadakan biasa setahun sekali. Ya. Berikutnya kami ada sharing ilmiah ya bersama Dr. Ajimsha dan juga Janani biasanya dan seperti yang kita lakukan pada hari ini ya dokter semua ya untuk mengupgrade ilmu. Ya, berikutnya ini saya perkenalkan tim Jakarta, tim Nobel Jakarta yang terdiri dari saya sendiri untuk tim alat bantu dengarnya. Yang untuk tim implan kokleanya ada Mbak Marsha Fiona sebagai clinical manager. Yang berikutnya ada Bang Roy Andre Simanungkalit sebagai business development di tim implan. Dan berikutnya ada tim EVT Gali Anggisa Aurora untuk rehabilitation manager. Terus yang berikutnya ada Victoria, Mbak Victoria itu sebagai EVT practitioner di Jakarta. Ya, Nah, di sini juga saya mau menginformasikan bahwa kami Nobel Audiology Center saat ini sedang ada petugas kami yaitu Mbak Gali yang menjadi rehab manager sedang menempuh pendidikan sertifikat FET yang dimana sangat-sangat langka di Indonesia yang nantinya tim FET atau practitioner FET kami itu akan under supervisinya beliau ya yang dimana beliau sedang menempuh pendidikannya di Ajimsha Academy dan dimentori oleh Janani ya sebagai speech pathologist dan FET certified dari Advanced Bionic atau AB. Ya, untuk informasi lebih jelasnya dokter semua bisa menghubungi kontak kami mulai dari sosial media kami atau website kami atau bisa dengan scan barcode ataupun dengan ke nomor WhatsApp kontak center kami. Ya, hear clearly, live fully. Thank you. Sebelum saya tutup, saya mau memberikan salam dulu kepada Dr. Ika Dewi Mayangsari, Sp.T.H.T. selaku Kepala Divisi Departemen THT, Dr. Rahmanova Sp.T.H.T, Dr. Harim, Dr. Semiramis, dan Dr. Ayu Sp.T.H.T. Ya, terima kasih juga untuk para panitia yang sudah menyelenggarakan acara seminar edukasi seperti ini. Kurang lebihnya mohon maaf. Selamat pagi. Assalamualaikum warahmatullahi wabarakatuh.
Warahmatullahi wabarakatuh. Terima kasih banyak. Now we are at the end of our lecture. So to close this lecture, we will have Dr. Ajimsha as a head of Advanced Bionics Southeast Asia to give appreciation talk to the ENT department that will be represented by me as the moderator.